Dear Chair, dear audience, as the last presenter, I'm going to take back to the very tiniest, the most vulnerable populations that we care of as a pediatricians or as a neonatologist, to the very preterm infants. My name is Vivien Unger. I'm a final year pediatric resident working in Veszprém at the Csolnoky Ferenc Hospital and also conducting my PhD studies in the Semmelweis University. Here you can see the research that we are currently working on and what we would like to work on in the future. So let's start with the first one, which is about finding the optimal mode of delivery for very preterm neonates. This is a systematic review and a meta-analysis. Approximately 15, or as Ira mentioned, 13 million babies are born preterm annually worldwide, indicating a global preterm birth rate of about 11%. These preterm babies account for 35% of neonatal mortality. Very preterm infants who born before the 32nd gestational week are at high risk for death, medical complications, and neurodevelopmental sequelae. The optimal mode of delivery before the 32nd gestational week is still unknown. Despite the benefits regarding C-sections, there has been a huge variance in the rates of C-section rates, although we still don't know whether it's beneficial or not. Some studies found that C-section reduces mortality rates or the incidence of IVH, the intraventricular hemorrhage, although during C-sections, some complications might arise, such as delayed neonatal lung liquid absorption, neonatal gut dysbiosis, or high rates of maternal morbidities. Although during prolonged birth asphyxia may occur, which is a known risk factor for intraventricular hemorrhage. Therefore, C-section might have a role in prevention of IVH. To formulate our clinical question, we used the PICO framework. We investigated preterm infants who were born before the 33rd gestational week. We compared actual and planned C-section and vaginal birth. After the systematic search, we found 19 eligible articles. And let's see the results. In this forest plot, we compared the planned mode of deliveries and neonatal mortality. In this one and in the upcoming ones, we use odds ratio as a measure of effect. If odds ratio is 1, there is no difference between the two groups. If odds ratio is below 1, so the study is situated on the left side of the line, babies who born by a cesarean delivery have lower odds of death than babies who born by a vaginal birth. As you can see in the first 4 studies, we included singleton breech pregnancies. Among them, odds ratio was 0.56, which means that singleton breech babies born before the 32nd weeks of gestation have almost 40% smaller odds of death than among babies who born by vaginal birth. In case of singleton vertex and twin pregnancies, more data is needed to conclude. In case of analyzing the data based on the actual mode of deliveries, we found similar results regarding singleton breech pregnancies. There is also a significant decrease in the odds of death if babies are born by a cesarean delivery. In case of singleton vertex pregnancies, we found no significant difference regarding the different modes of deliveries. And for twin pregnancies, there was not enough data to do calculation. Another primary outcome was intraventricular hemorrhage. Here we listed 3 studies which analyzed all grades of intraventricular hemorrhage. You can see that there is a statistically significant difference between the 2 groups, but I would like to highlight the results of the severe grades of IVH, to be precise, the grade 3 and grade 4 IVH cases based on papaya grading. In this case, we found no significant difference between the 2 groups. And when interpreting the IVH cases, the severe IVH cases has a more pronounced effect on the long-term neurological consequences of these preterm babies. Here you can see all of our data that was pooled and calculated, just highlighting the differences between the planned and actual mode of delivery. And now let's see how our findings align with the recent guidelines. In case of singleton vertex pregnancies, according to the WHO, ACOG, and ARCOG, no routine C-section is indicated. In case of singleton breech pregnancies, when there is a maternal or fetal comprise, they indicate only a C-section in those cases. And regarding twins, not enough data available, and there is no clear guidelines to offer. So, implication for research, of course, more prospective studies are needed from this population, especially from homogeneous populations. And we might conclude that focusing on neonatal outcomes, cesarean delivery could be or should be the optimal mode of delivery for extremely and very preterm breech pregnancies. I'm very happy to share that our manuscript was accepted just last night. So we are going to be published in the AOG. And the second topic is about the characteristics of periviable infants in Hungary, which is going to be a registry analysis. The definition of the limit of viability is based on the ability of the fetus to survive outside the womb when supported by the most advanced medical care. There has been a change in the limit over time. In the 1980s, it was around the 28th gestational week. Meanwhile, 40 years later, it decreased to the 22nd, 24th gestational week. Although this definition doesn't consider the chances of survival and the survival's quality of life. The gray zone is set between two boundaries. The lower limit is the absolute limit. Under 22nd gestational weeks, babies don't survive. But the other limit is where a baby survives and the survivors have a good quality of life. So babies who are born during this period meant to be really big issues for the parents and for the healthcare providers. Therefore, we need our own and up-to-date data to provide them for prenatal counseling. The data source is the Hungarian NICU database, and our plan is to analyze the data from 2005 till 2022 in 4 different epochs, and to provide timely and accurate data about this periviable infant. Just a show quick from the really first descriptive analysis, it's not even an analysis. We have 4,390 babies' data ready to be analyzed. I'm at the data cleansing phase, so there is a lot to do still. Here you can see the summary of my 2 ongoing and hopefully ongoing projects. And I'm happy to share that we are going to present the first topic in Ljubljana in 2 weeks. So thank you for your attention, and let me finish my presentation with a quote: "From a little spark may burst a flame." Thank you.
Do you know what is the standard care regarding 22-23 weeker in Hungary or in your unit, or do you have such a standard care?
Well, I think it differs even in our country, in our unit or in Veszprém, as I can tell. So based on the Hungarian law, if a baby is born and signs any kind of signs of life, then we have to be active. So this is what we have to do. But there are these ethical questions, whether there is a boy fetus without antenatal corticosteroid treatment from a huge infection of the mother. Should we even start this active management? So I can't say that we do this and this in every case, because it's an individual care at this phase.
Could you make a subgroup analysis for gestational ages?
Well, it would have been very nice to do a stratified data for all gestational ages. We could do only for extremely preterm infants who were born before the 28th gestational week, but we found no significant data for them.
Just a simple question. Congratulations on the acceptance of your paper. The conclusion was that more studies in homogeneous populations. Could you elaborate a bit on that? Why would you want homogeneous populations?
Yes. Thank you for your question.
And what does it mean?
Yeah. Okay, so I forgot to mention in one of the slides that we excluded cases that were complicated with preeclampsia and placental abruption. So at the time point when an obstetrician or neonatologist have to make a decision which way is safer, C-section or vaginal birth, we wanted to include only that population when both arms could be chosen. So there is no distortion of the data, whether it was influenced by a huge bleeding or under maternal indication necessitating a C-section. I meant by homogeneous population that only for periviable infants or only for very preterm infants between 28th and 32nd gestational week, because it differs. I think it differs how we manage them. And also it would be very nice to have a baseline population exclude gestational diabetes or other maternal factors that could definitely influence the outcome of the baby. It would have been really nice. Most of the studies tried to minimize these confounding factors, but we could only select those which were so we excluded preeclampsia and placental abruption. Also, we excluded fetuses with congenital malformation, or I can say none of the articles examined those fetuses who were diagnosed with congenital malformations. And we tried to look into the small for gestational age babies, because it could definitely influence the outcomes. There were only 3 studies that included these babies, but it wasn't excluded.
So you want to reduce bias and also reduce random error,
Yes.
error by this.
Yes,
And,
if it's even possible.
And how about the generalizability of the results if you have a very clean population?
Sorry, I didn't
The
hear that.
generalizability of the results if you have a very clean population, what would happen?
And there is an obstetrician who is able to perform a vaginal birth for a breech birth, maybe, or just generalize Hungarian or European data for the US, you mean this?
No, just if you have a very selected population, perhaps for a good reason, as you explained. So, what would it mean for the generalizability of the findings and conclusions you are able to make?
I think this is the way we can do a generalizable data. All of the studies were cohort studies. No RCTs, it's not visible in this topic. So if we take into account all of these confounders, it is a generalized data, I think.
Did you try or made an attempt to check whether C-section rate in the general population, whether has an association with the difference of the outcomes between the planned vaginal, planned C-sections? My thoughts behind this is that if generally the C-section rate is high, then the general attitude is of the team is that C-section is beneficial in this situation, and those who delivered vaginally, this is rather an accidental one, so an uncontrolled situation. So therefore, theoretically, probably, if the general C-section rate is high,
then they are going to go for a C-section.
Yeah. Did you check it or made an attempt statistically to check this bias?
Actually, only one of the articles stated what was the unit in their ward or in their country. It was Netherlands. It was from the Netherlands.
Okay.
And they made a sensitivity analysis, I guess, what was the policy at the time, whether they are go for these very preterm babies a C-section, or they are safe to go for a vaginal birth. But it was only one article that analyzed the data from this aspect.
Okay, but
we didn't. No.
Okay, so a lot of studies selected. So these were multi-center trials mainly, but one part of the world and could be representing that representative that the studies must be different between the general rate of C-sections. And if you ranked these studies based on the rate of general rate of C-section, okay, then letter after acceptance. Okay, but it would be interesting.
Yeah, definitely.